It's a great honor to introduce our second speaker, Dr. Hanane Chaoui. Dr. Chaoui is a consultant toxicologist with MD and PhD and is the head of the Toxicovigilance department at the Center Anti-Poison Anti-Pharmacovigilance de Maroc in Morocco. And she's internationally recognized for her work in scorpion envenomation surveillance, clinical toxicology, and poison control systems, particularly in regions where the scorpion stings are a major public health concern. And her presentation, The Scorpion Stings, of clinical classification, red flags for severe envenomation, and principles of management. We are truly privileged to have you, Dr. Chaoui, and over to you.
Thank you very much, Professor Kavinda. I'm very happy to be with you today. I'm going to share my presentation. Do you see my presentation? Does my screen, is it shared?
Yes, we can see, Hanane.
Yes, thank you very much. So, good morning, everybody. So I'm very happy to share with you how we manage sting and envenomation by scorpions in Morocco. Before I start my presentation, I want to tell you some background how we the management flow charts have been developed in Morocco. I want just to say that before the year 2000, we didn't have any strategy of management of scorpion bites and envenomations in Morocco. We had a lack of understanding of the mechanism of scorpion envenomation, and we had also the use of inappropriate and ineffective therapies by our healthcare professionals, like antihistamines, corticosteroid, and we had also an anti-venom, but it was not adapted to our species. So since 2001, there was a national control campaign, and we had a training of trainers on clinical management of scorpion envenomation. Then we had done a therapeutic protocol revision of the management chart. And then we had updated the clinical management guidelines during the national meeting on 2005, and we have developed a consensus on the management of scorpion envenomation with involvement of national and international experts. Then we had developed in 2007 what we call therapeutic kits. These therapeutic kits are kits that include all medicines and drugs that will be needed in the case of sting and scorpion sting, including the medication K. What we use in Morocco is dobutamine. Then in 2009, we had an expert consensus on the classification of scorpion stings and envenomation. And also we had in 2018 a clinical trial, randomized the phase 3 clinical trial on scorpion anti-venom use in Morocco, but the results weren't published because the sample size needed to be expanded. So what are we talking about? As you have already mentioned, scorpion stings are orphan disease, and they can be considered as public health problem. The specificity of Sri Lanka, or the old word, sorry, here is the old word, not few word, it's the old word, like in Africa, in Asia, in Europe, that we have the Butidi family. In Morocco, we have the most venomous scorpion is Androctonis mauritanicus, and in Sri Lanka, as you have mentioned, you have the Hotantota tamulus. the characteristic of these scorpions that they have severe cardiorespiratory symptoms. And they are potentially life-threatening, as we have seen. It's different from stings from the Americas scorpions, like in the New World, like in the United States and in Mexico. So what is the physiopathology of this envenomation? The mechanism of action of scorpion venom primarily acts on ion channels and synaptic transmission, with a particular effects on cellular sodium metabolism. And the clinical manifestation of this species of Old World Buthidae family is mainly explained by three major types of disturbances: hemodynamic disturbances, hormonal disturbances due to massive catecholamine release. This is very important. It's what we call the catecholamine storm, and also visceral involvement, which is less frequent but more severe. We can see this visceral involvement in severe cases. In the Old World scorpions, like for Buthidae, for Asian scorpion, and for Moroccan scorpion, North Africa scorpion, the cardiovascular mechanism of envenomation occurs in two phases. The first phase is a peripheral vascular phase, secondary to the massive release of catecholamines and other vasoconstrictive peptides. And the second consists of structural, morphological, and functional alteration in myocardial performance. In the first phase, which occur rapidly after scorpion envenomation, it's characterized by a transient increase in systemic arterial blood pressure. In rare cases, arterial hypertension may coexist with pulmonary edema. In the second phase, corresponds to myocardial failure. It's characterized by elevated left ventricular filling pressures and reduced cardiac output. This is very important because when we see a cardiac shock, it is a more cardiogenic shock than hypovolemic shock. So we can also observe the pulmonary edema that is observed is a hemodynamic one that confirms that is a cardiogenic pulmonary edema. And there is three main hypotheses that have been proposed to explain cardiac dysfunction. This includes the adrenergic myocarditis resulting from a massive catecholamine surge, toxic myocarditis caused by the direct effects of scorpion venom on myocardic cell membranes, and also myocardial ischemia. So scorpion cardiomyopathy is characterized by three distinctive features: its severity, it's both the two ventricles are involved, and its reversibility. This is very important because as we can see, the children who were well managed have later their myocardial function that is at 100%. The mechanism of the autonomic nervous system response to scorpion envenomation is the stimulation of the sympathetic autonomic nervous system, which is responsible for tachycardia, arterial hypertension, mydriasis, profuse sweating, and urinary retention. The stimulation also of the parasympathetic autonomic nervous system, which lead to bronchial hypersecretion, hypersalivation, bradycardia, arterial hypertension, priapism, and meiosis. And also, although either sympathetic and or parasympathetic effects may predominate, clinical manifestations are most often mixed, reflecting simultaneous activation of both autonomic pathway. So the cornerstone of a rational management of a patient stung by a scorpion is the distinction between a simple sting without envenomation and the sting associated with envenomation. This is the cornerstone of the management in Morocco. And as the previous speaker have presented, she presented 3 cases. I think that the third one, it was just a simple sting, what we call a dry sting without envenomation. So Moroccan epidemiological data shows that out of 100 patients stung by a scorpion, fewer than 10 develop envenomation. Indeed, approximately 90% of scorpion stings are dry stings without no venom injection. The distinction between a simple sting and a sting with envenomation is based on a careful medical history obtained from the patient and relatives and through local and local regional examination and a precise systematic general clinical examination. So what are the case steps in patient management? First, reassurance and patient confidence. Every scorpion sting should be considered as a potential envenomation until proven otherwise. Then, encourage patients to seek medical care as early as possible and eliminate traditional beliefs and misconceptions, which may lead to delays in medical management. Then we have to confirm the sting. The sting site is usually single. The scorpion is often identified by the patient or relatives. And then what are the circumstances of the sting? We need to precise the geographical region and location, which may suggest the presence of venomous species. And then precise dates, time, and circumstances of the sting. After that, we have to precise in medical history a very important thing, which is the post-sting time. The post-sting time is defined as the time interval between the moment of the scorpion stings and the time of clinical examination. The epidemiologic data, the Moroccan epidemiologic data have shown that a period of 4 hours is considered necessary for the appearance of signs of envenomation, according to the Moroccan data and also to the Maroc classification, which has been adopted by the World Health Organization. Meaning that more than 4 hours, the probability of appearance of envenomation signs are very, very low. So the signs of envenomation appear within the 4 hours post sting. Then we have to assess for systemic signs. They may appear rapidly within the first 5 minutes following the stings and may be transient. This is very important, so we have to be careful. And after that, we do a local examination. We specify the site of the sting. We look for local signs. We look for local regional signs, and we do general examination. We measure and record blood pressure, heart rate and rhythm, body temperature, respiratory rate, and respiratory pattern. And we take the body weight. We look for general systemic signs, look for predictive signs of severity, including this pediatric population, age under 15, fever more than 39 Celsius, profuse sweating, recurrent vomiting, and priapism. And assess for sign of life-threatening distress. Then we have to stratify the patient, to classify the patients. These steps will allow classification of patients into 3 categories. Class 1 are patients with a simple sting without envenomation. Class 2, it's patients that are envenomed but without severe manifestation. And class 3 are severe scorpion envenomation. How we stratify and classify the patient. Class 1 is the presence of 1 or more local signs such as pain, erythema, edema, numbness, etc. But there is no systemic signs. Pain is localized, very intense, and may persist for up to 24 hours. But I insist, local pain Even if it's intense, it's not a sign of envenomation, local pain. So this class 1 with local signs, it's simple sting without envenomation. Class 2 is the presence of venom in the systemic circulation, is manifested by general systemic signs, including hypothermia or hypothermia, chills, elevation of systemic arterial blood pressure, which is frequent, nausea, abdominal pain, abdominal distension, diarrhea, urinary retention, among others. Predictive signs of severity are that indicate that there is an imminent progression to class 3 are vomiting, profuse sweating, fever more than 39 degrees Celsius, and priapism. For class 3, it's a severe envenomation with vital organic failure. Cardiocirculatory distress, most frequent cause of death, cardiovascular collapse or shock, tachycardia rhythm or conduction disorder, elevated troponin, which signs myocarditis. Acute respiratory distress secondary to cardiac failure, tachypnea, cyanosis, bronchial congestion, or acute cardiogenic pulmonary edema, or a neurological distress secondary cerebral injury due to hypoxia manifested by agitation, irritability, fasciculation, altered consciousness, seizures, pupillary abnormalities, and the progression is to coma of variable depth. So this is the classification that was adopted in May 2009 and was developed through an international consensus and published. Class 1 is local manifestation, as we have seen, including pain, local pain. Class 2 is minor systemic manifestation, not life-threatening, and class 3 is major systemic manifestation that could be life-threatening. So the classification is very important. Simple sting is class 1. There is no envenomation, it's a dry sting. And the envenomation, we treat patient with envenomation for class 2 and class 3. So classical signs of envenomation typically occur soon after the sting and are rarely observed beyond 4 hours. So simple stings represent more than 90% of cases. They are due to non-venomous species of scorpion, venomous species, but the sting was dry without injection of venom, and or injection of very small venom dose comparing to body weight. It's why children are more vulnerable. They are vulnerable or at-risk population because of their low weight, so there is higher venom concentration. And the envenomation, meaning class 2 and class 3, represents less than 10%. They are due to venomous scorpion, venom injection, and sufficient venom dose relatively to body weight. So the management of an envenomed patient or sting patient must differ from that of a patient with a simple sting. When we have a patient, and specifically a child with scorpion sting, it's crucial to distinguish or to make the distinction if it's an envenomed patient, meaning class 2 or class 3, or it's not an envenomed patient, just a stung patient. So what to do when we receive a patient with a scorpion sting? In the event of a scorpion sting, we have first we have to remove the scorpion from clothing, shoes, bedding, and capture or kill it if it's possible. Move the victim away from the seat of the sting. Note the scorpion size and color if it was identified. Reassure the patient and relatives. Record the time of the sting. Record the time of the sting is very important. avoid traditional or non-medical treatment, immediately evacuate the patient to the nearest healthcare facility, and cooperate with healthcare professionals. Practices and traditional practices to avoid are scarification, tourniquets application, suction, application of gas, and application of certain medication that are not useful in the case of scorpion stings. If it's a class 1, meaning class 1, no envenomation. This is just a simple sting. We do a symptomatic treatment of local signs. We disinfect the sting site using a non-alcoholic antiseptic. We give paracetamol analgesia or antalgia, acetaminophen in children 60 to 80 milligram per kilo per day, divided into 4 doses. We apply lidocaine, prelocaine cream, anesthetic cream with the dressing. And we can also use ice pack if anesthetic cream is not available. And we put a patient in observation during 4 hours of post-sting time with continuous monitoring of vital sign, so we can decide if it is a class 1 or class 2 or class 3, if it's an envenomation or a simple sting. And we do awareness and education, sensitization of the family and the relatives. If during the period of observation the patient develop systematic sign but without life-threatening signs, we hospitalize the patient closely to an ICU, an intensive care unit. And in the absence of predictive signs of severity, what we have seen, priapism, vomiting, and the children under 15, we do symptomatic treatment of systematic signs, monitoring of vital signs every 30 minutes until complete and sustained resolution of all symptoms. Usually, it's within 24 or 48 hours. In the presence of predictive signs of severity, we stabilize the patient and we transfer with no delay to the intensive care unit and manage it as class 3 envenomation. For class 3 patients or class 2 patients with predictive signs of severity, we stabilize the patients. The patients have to be accompanied by a healthcare professional in semi-sitting position or recovery position with upper airway clearance in case of impaired consciousness. We do a large bore peripheral. We put a large bore peripheral intravenous access for baseline fluid therapy. We put 5% dextrose solution with sodium chloride and with potassium chloride. And we also do oxygen therapy according to available resources, nasal cannula, face mask or catheter or high concentration mask, as with a flow rate of 3 liters per minute. And we can also do endotracheal intubation and bag valve ventilation in case of respiratory or neurological distress. So for class 3 patients or class 2 patients with predictive sign of severity, we initiate inotropic therapy. Inotropic therapy, we have seen that in the physiopathology of the envenomation, that the mechanism of death and the mechanism of complication of the envenomation of scorpions from the old world, especially the Butidae family, is the cardiac arrest and cardiomyopathy complication. So we use dobutamine. Dobutamine is very efficient in to reverse the cardiomyopathy associated with scorpion envenomation. We use a dose of 5 micrograms per kilo per minute via infusion pump or drip. And I can give you the presentation we have. We dilute the dobutamine in saline chloride 250 milligrams into 150 milliliter. And in case of cardiac arrest, we can practice chest compression, bag mask ventilation, intravenous access with the saline chloride, and we can use adrenaline 1 milligram IV bolus repeats every 3 and 5 minutes. These measures must under no circumstance delay the transfer to the ICU. So the use of dobutamine for class 2 patients with predictive sign of severity or for class 3 patients must not delay the transfer to the ICU. Sorry. How we use dobutamine? We are going to dilute 1 ampoule of dobutamine of 250 milligram in 250 milliliters of 0.9% of saline chloride. So we have 1 drop of the preparation is equal to 50 microgram, and we start dosing. The starting dose is 5 microgram per kilo per minute. For example, for a child weighing 10 kilo, if we want to use, we are going to use 5 milligram per kilo per minute during 10 minutes. It will be 50 microgram per minute. It's 1 drop per minute. For child 2 of 15 kilo, we have to use 75 microgram per minute. It's 1.5 drops per minute, but in practice, we can increase to 2 drops per minute. For class 3, we hospitalize in ICU. We stabilize patient, we control mechanical ventilation, we put controlled mechanical ventilation with endotracheal intubation if it's necessary. We insert urinary catheter and nasogastric tube, and we start symptomatic treatment of local and systemic signs as previously described. We use, of course, dobutamine, and we use also for symptomatic treatment for seizures diazepam, for agitation midazolam, and for arterial hypertension, which is usually uncommon and transient. If there is no visceral decompensation, we don't treat the arterial hypertension. But if the treatment is required, we can use nicardipine at the dose of 1 to 2 milligram in IV bolus. We start to manage the life-threatening distress. The treatment aims to maintain adequate function of the major vital systems, cardiac, respiratory, and neurological. And at all times, the physician must adapt treatment to the patient's clinical condition, which highlights the importance of intensive monitoring of vital function. The monitoring has to be each 30 minutes. So for cardiovascular distress, we use dobutamine as described, 250 milligrams ampoule diluted in 50 milliliters of 0.9% of saline chloride, saline solution, administered via syringe pump through a peripheral IV line. And we start with a mean dose of 7 microgram per kilo per minute and increase by increments of 2 microgram per kilo per minute every 15 minutes until clinical stabilization is achieved, defined by resolution of shock signs, normalization of blood pressure and respiratory rates, and recovery of urine output greater than 0.5 milliliter per kilo per hour without exceeding a maximum dose of 20 microgram per kilo per minute of dobutamine. After sustained hemodynamic stabilization for 24 and 40 or 48 hours, the dose should be gradually reduced by increments of 2 micrograms per kilo per minute every 15 minutes. Treatments may be discontinued once the dose reaches 4 micrograms per kilo per minute. We have to use a careful fluid resuscitation using small volumes of saline solution at 5 milliliter per kilo in children and 250 milliliter in adults over 30 minutes, under close monitoring of heart rate and blood pressure. For respiratory distress, we put the patient in recovery position. We put nasal oxygen therapy if it's insufficient and in the presence of tachypnea, more than 30 breaths per minute, profuse sweating, cyanosis, shock, altered level of consciousness. We practice endotracheal intubation and with controlled mechanical ventilation. For neurological distress, we put oxygenotherapy, recovery position. We use midazolam for seizures, and we intubation if Glasgow Coma Scale is under 9. For paraclinical tests, they are not very important as the clinical classification of the patients and the treatments of the symptomatic and the treatment of the patient and the use of dopamine. So we have their absence must never delay the patient's management. So we do complete blood counts with the hemoglobin and hematocrit, serum electrolytes, total protein, blood glucose, renal function tests, CRP, CPK, troponin, arterial blood gas analysis if it's possible. For imaging and cardiac investigation, chest X-ray if possible, electrocardiogram and cardiothoracic scan, but in practice it's not available. What about the serotherapy? What about the management that I have presented to you? It's without serotherapy. For the serotherapy, for the antivenom use is widely debated. The use is widely debated in the literature. It's considered essential by some authors, but of limited or no clinical efficacy by others. Recent experimental and clinical data have raised serious doubts regarding its clinical effectiveness. But just I want to precise that I am talking about our the PTD family, the old species scorpions, not the new one, not the scorpions of United States and Mexico, scorpions of India, of Asia, and of North Africa. So the first explanation of the limited efficacy of anti-scorpion antivenom lies in the physiopathology of severe envenomation. The venom effects are mediated through the release of multiple endogenous mediators. We have seen the catecholamine storm, on which the antivenom has no effect. The second explanation relates to major pharmacokinetic differences between the venom and the immunoglobulin contained in the anti-scorpion antivenom. The venom, which low molecular weight, acts much faster than the administered immunoglobulin or antivenom. Here, I want just to show you the clinical trials that have been conducted between 1998 and 2025, showing that it's in French, but I will give the conclusion. So these are all the clinical trials that shows that. And here, there is meta-analysis and systematic reviews about the use of scorpion antivenom for species from scorpion species from the Old World. The conclusion of this meta-analysis and clinical trials, there is acceptable level of evidence in favor of the use of serum antiscorpionic or scorpion antivenom against New World species. such as centroides in the United States and Mexico, because there is neuromotor disorders. But this evidence is not extrapolable to patients in India or in the Maghreb, North Africa, with severe cardiovascular disease. There is insufficient level of evidence to recommend scorpion antivenom in the envenomation of the Old World, especially with Buthidae family like Androctonis, Buthus, and the Indian scorpion. So it was about the use of scorpion antivenom. What about, so we have classified our patient. We have treated class 1 like a simple sting with symptomatic treatment. For scorpion, for class 2 or class 3, if it is class 2, we treat a patient with symptomatic treatments. If it's class 2 with predictive signs of severity, or if class 3, it's the hospitalization in ICU, and we start dobutamine treatment to prevent cardiovascular cardiac shock and cardiomyopathy. For the monitoring and follow-up, we continue monitoring of vital sign, blood pressure, heart rate, cardiac rhythm, respiratory rate, and temperature. Capillary refill time, normally it has to be under 5 seconds. Level of consciousness with Glasgow coma scale, hourly urine output, oxygen saturation, and integrity and patency of intravenous access. We adjust the treatments and adapt it according to clinical evolution, and we document all these parameters and intervention every 30 minutes in the ICU, in the intensive care unit. So this is the guideline, the Moroccan guideline that has been developed after the consensus meetings that I have presented to you. So we can see that this is in French. We classify the patient class 1, class 2, class 3, and here is all the management guideline that I have presented. Local examination, general examination, class 3, the use of other medicines, how we use dobutamine, and the detail of the management of the patient. Here I have put this graph just to show you the lethality rate in Morocco since we have started to apply this management guideline. You can see that before we had this strategy, we had the use of dobutamine, and we have this is the consensus of management of the patient. Sorry. Here in black, we have the general lethality rate. This general lethality rate moved from 2.37 to 0.14 in 2024. But this general lethality rate is not it's not important rate. Why? Because in this stung patients, 90% of them will have a good evolution, will not die, because 90% are simple stings, are not envenomation. So what is important to monitor is the lethality rates per envenomation. In the denominator, we put envenomated patients, not all stung patients. So this is the lethality rate per envenomation. It's the blue one. It went from 7.1 to 1.28. And also another rate which is important is the lethality rate in children under 15, because they are the population at risk. It went from 5.7 before the management guideline and to 0.47 without the using of antivenom. So to conclude, the cornerstone of a rational management is the distinction between a simple sting without envenomation and a sting with envenomation, because it's obvious that we are not going to apply the same treatment to in the case of simple sting and in the case of an envenomation. Management in Morocco is based on a standardized guidelines since 2001, improved and validated in 2005 by national and international experts, strengthened in 2007 through the distribution of therapeutic kits containing all necessary medication and consumables supplied to all regions of Morocco, and especially these kits contain dobutamine. The treatment is primarily symptomatic with the ICU management of severe cases. A clinical audit system for fatal cases has been implemented in hospitals to identify system failure and implement corrective actions, and no patient received scorpion antivenom. Thank you for your attention.
Thank you, Dr. Chaoui, for your very insightful presentation. I hope it was kind of very useful for all the listeners who joined today.